शुरू हो ना
जी
Today's lecture is on investigations in renal diseases, that is renal function test. Uh, you have to keep in mind the different functions which the kidney perform. This we have already discussed yesterday. For example, excretory function, uh, endocrine function, regulation of blood pressure, erythropoietin, uh, calcium metabolism, etc. You have to keep in mind these functions, and on the basis of these functions, we can perform the different forms of renal function test. Now, this is a diagrammatic representation of the excretory function of the uh, kidneys, which they perform. Glomerulus filters everything from the blood, and then there is selective reabsorption of different things, and also secretions leading to the final production of the urine. As we know, there are 1 million nephrons in each kidney, which is an independent functional unit. Now, each nephron has got the glomerulus, which filters out the blood, which is called glomerular filtration rate, and then there is reabsorption in the proximal convoluted tubule, almost 75% of water, sodium, and glucose, amino, everything is reabsorbed mainly in the proximal convoluted tubule. Then there is in the loop of Henle, there is reabsorption of sodium and water, and then the still collecting tubule adjustment in the electrolytes and acid-base homeostasis under the influence of ADH and aldosterone. And the final product is the urine, which is around 1.5 to 2.5 liters in 24 hours. Now, proximal convoluted tubule, as I have already told you, it absorbs almost everything, and then there is selective reabsorption and secretion at different parts of the tubules. So you just have to remember this thing. We already know the functions of the kidney. We have already discussed them in detail. Excretory function, metabolic waste products, drugs and chemicals, water and electrolyte balance, acid-base balance, hormonal functions, erythropoietin, activation of vitamin D, and activation of angiotensin, nogen by renal. And metabolic function, which is gluconeogenesis. It is not a major function, but remember the above functions of the kidney. Now, on the basis of these functions, we can proceed with the different kind of tests which we perform on patients with kidney disease. The most important being urine analysis. This we will discuss in detail. Then urea and creatinine, which is a measure of the degree of renal impairment. It is routinely performed in patients with kidney diseases. GFR, how to calculate the degree of renal impairment, that is glomerular filtration rate, how much kidneys are affected. It is calculated by GFR. Then renal profile. In renal profile, there are battery of tests which we perform so as to narrow down the differential diagnosis. For example, if patient comes to you with anemia, we think in terms of chronic kidney disease. Similarly, patient comes to you with, say, low calcium. Immediately the metabolic function, the endocrine function, calcium regulation comes to the mind, etc. Then imaging, and finally the kidney biopsy, which is a diagnostic tool to establish the diagnosis of kidney disease. Now, before proceeding with urine analysis, which is commonly called urine DR, DR stands for detailed reports. It is a very easy test, a very commonly used test, but interpretation requires some knowledge. And for this, it gives you important information regarding kidney diseases like hypertension, edemic patients having nephrotic syndrome with proteinuria, raised creatinine patient with acute kidney injury and chronic kidney disease, or there may be dysuria, flank pain, and hematuria, which indicates towards obstructive uropathy. And patients can present with systemic diseases like diabetes, autoimmune diseases, and vasculitis, having different urine analysis findings. The interpretation of the urine DR, history, examination, and other laboratory investigations will help us in establishing the diagnosis of kidney disease. Now, How do we perform urine analysis? Either by gross examination, dipstick evaluation. Dipstick method only is a sort of a screening test. If there is some abnormality in the dipstick, then we have to confirm it by other biochemical methods. And then microscopic examination, this is not performed by dipstick. Every dipstick result needs to be uh, confirmed with microscopic examination. And for this, we need trained clinician, proper collection, and prompt examination of the urine. Now, how to collect urine for urine analysis? It should be a midstream sample. Midstream sample means that the easier way of getting the midstream is to tell patient to start passing the urine. Once the urine stream is established, brings the bottle to the urine which is he is passing, and then remove it. So you avoid taking the initial urine sample and the late urine sample. It's the midstream urine sample. It is also called clean catch. It has to be done in a very clean environment. The bottle should be not sterile for urine analysis. It should be sterile for urine culture. But it should be clean. The bottle and the urethra and the external genital parts of the patient should also be cleaned. In hospitalized patients who are unable to avoid, we catheterize the patient and take the samples for urine analysis. We clamp the catheter. We do not take urine from the catheter tubing. It should only be taken from the catheter and not from the urine bag also. It should not from the urine tubing, not from the urine bag. It should be taken from the catheter. The catheter is connected to the urine tubing, and disconnect it, take the urine sample, and then reconnect it. And in those patients in whom we are unable to catheterize the patient, he is in retention. In that situation, we do a suprapubic aspiration. We put needle into the bladder and collect the urine for sample for testing. The first thing which we do once we have collected the urine, or the first thing which we should do is identify the odor of the urine. The normal odor of the urine is aromatic. Aromatic means those odors which spreads into the environment. It can be pleasant, it can be pungent, it can be unpleasant as well. Ammoniacal odor is because of decomposition, long-standing, or an UTI. Ammoniacal means ammonia. When you open a fridge, you feel it's kind of a smell. Especially the freezer part of the fridge, when you open it, you can feel that kind of smell. Then acetone, sweet smell, pungent smell, is a feature of ketonuria, diabetic ketoacidosis, or if the patient is starved. Foul smelling urine is commonly seen in UTI, and mousy, मरे हुए चूहे की smell की तरह is a feature of female ketonuria. These are the different odors of the urine. And then the color. Color is very important. The normal color of urine is light yellow or straw colored. Sometimes it is also called amber colored. It is basically due to the presence of pigment called urochrome. If the urine is turbid, it is mainly because of cells and crystals embedded in it. Red or brown colored, blood and other causes. Whenever you see a urine which is the red colored, you have to centrifuge it. If the supernatant is red, it usually signifies presence of heme, which is because of hemoglobinuria or myoglobinuria, and if the sediment is red, then it is hematuria. Negative rediment sediment is usually seen in a red colored urine due to dyes, drugs, beetroot, rhubarb, or in porphyria. White colored urine is in pyuria or chyluria. Chyluria is a lymphatic obstruction. You literally get absolutely milk colored urine. Green color is because of methylene blue or amycretin. These are drugs. Black on standing is alkaptonuria, and purple urine is because of bacteriuria. It is also called purple urine bag syndrome. It's a chemical reaction. So this is the color, normal color of the urine. Presence of urochrome, light colored, sometimes becomes dark colored when it is the urine is concentrated. Concentrated mild dehydration and vitamin B, the urine color is slightly darker. Orange color urine is basically because of drugs. Example is rifampicin. And pinkish color is ingestion of lot of beetroot can give a pinkish color to the urine. These are the variation in urinary color from amber to the concentrated to red to cola colored urine, which is a feature of post-streptococcal pneumonephritis. This is the cola colored urine. Now, dipstick testing identifies the abnormal constituents in the urine. It is easy, convenient, but operator dependent. Means that you have to match the color of the urine with the different color of the dipstick with the chart provided in the dipstick, and it gives you information about the pH, specific gravity, protein, blood, that is hemoglobin, glycosides, nitrates, and glucose and bile. Prompt testing is essential. Otherwise, if there is a delay, if the urine is kept standing and then you apply dipstick, there are pH changes and contaminant bacteria can grow in it and give you a false positive nitrate test. And for infection, you have to confirm it by urine culture. Now, this is a dipstick. You dip this stick into the urine and then match the colors of different elements of the urine with the chart provided in the dipstick jar. Again, how a dipstick is performed. Very easy. You just have to dip the urine into the dipstick into the urine and match it with the chart provided in the dipstick jar. This is a chart showing leukocytes, nitrates, the urobilinogen, protein, and different colors of the protein. As the protein increases, the color changes. Then sugar, blood, etc. pH. A normal urine pH is acidic, ranges from 4.5 to 7.5 to 8. Acidic urine is usually seen in patients who are having high protein diet or after heavy exercise, or it can be in acidosis due to any cause like diabetic acidosis, respiratory acidosis, or high fever. Alkaline urine is usually seen in heavy metal poisoning, citrus fruit intake, milk, and antacids. UTI, in UTI also, the urine is usually alkaline, and in alkalosis, metabolic alkalosis. Now, how do you check pH? It is ideally it should be done with a litmus paper, but dipstick also gives you a rough estimation of the pH of the urine. Specific gravity. This is the important test. In fact, it shows the concentrating ability of the kidneys, ranges from 1.016 to 1.025. Low specific gravity is usually seen in patients with polydipsia, that is compulsive polydipsia, वो लोग जो ज़्यादा पानी पीते हैं, in diabetes insipidus and pyelonephritis. High specific gravity is seen in dehydration, concentrated urine, nephrotic syndrome, diabetes mellitus because of proteinuria and glycosuria. Specific gravity बढ़ जाती है. Adrenal insufficiency, congestive cardiac failure, and extrarenal losses like fever, vomiting, diarrhea, and burns. Any condition which causes dehydration can give rise to high specific gravity. And then there is fixed specific gravity. No matter patient is hydrated, overhydrated, or dehydrated, the specific gravity remains the same in the range of 1010, which is equal to plasma specific gravity. And this is a feature of chronic kidney disease. This is how you measure this specific gravity with the specific gravity meter, also called hydrometer, but dipstick give you a fair estimation of the specific gravity. Uranometer you use to establish the specific gravity, check the specific gravity. Urine protein. Now, this is the most important constituents. In fact, in most of the kidney diseases, there is proteinuria. Dipstick color change from yellow to dark shade of green. And on the basis of color change, you say it is 1 plus albumin, 2 plus albumin, or 3 plus albumin. Dilute urine underestimate करता है, concentrated urine overestimate करता है. But one thing you should remember is the dipstick only detect albumin. There are other proteins which are in certain conditions which are passed in the urine, like in multiple myeloma. It cannot, dipstick will not be able to detect light chains of multiple myeloma and or Bence-Jones protein, and for that you have to do specific test for protein. Microalbumin is that albumin which the patient is passing, but in a very minute amount. It is called microalbumin, and it is usually not detected by dipstick, and for that, a specific test for microalbumin is required. Albumin can easily be checked by heat coagulation just by heating the urine. If there is a precipitate, it means albumin is present. But the confirmatory test is sulfonyl salicylic acid test. It also detects the light chains of multiple myeloma. And whenever a proteinuria is present, most of the time it is renal involvement, may it be nephrotic or nephritic. This is how you check protein in the urine by heating the urine. Sugar. Reducing sugars are easily identified on the dipstick method, but the actual test is the Benedict test. You take 5 ml of Benedict reagent, put 8 drops of urine and boil for 2 minutes. On the basis of color change, you say how much of sugar a patient is passing. Green precipitate 1 plus, yellow precipitate 2 plus, orange precipitate 3 plus, and if it is dark red precipitate, it is 4 plus urine. Now you have to remember the renal threshold. Any person have passes the sugar level above 180 milligram and start passing sugar in the urine. And this is the, so it any diabetic patient who has got a blood sugar of more than 180 will usually have sugar in their urine. And then there is a term renal glycosuria. It is patient is not suffering from diabetes, but because of certain physiological and pathophysiological changes, there is sugar in the urine, like in pregnancy, hereditary diseases like of tubules, like Fanconi syndrome or proximal renal tubular acidosis or heavy metal poisoning. These are the different colors of urine performed on the Rennetic test. Color changes from light blue to green to orange to red precipitate. Now, ketone bodies are basically acetone, acetoacetic acid, and beta-hydroxybutyric acid. Dipstick method gives you a magenta colored complex, which is on during the actual test, you get a purple ring. The ketone bodies are usually present in diabetic ketoacidosis, starvation, heavy exercises, high fat feeding, or sepsis or toxemia of the pregnancy like preeclampsia. You see, just by doing urine DR, you can exclude many diseases which are usually seen in patients with renal disease or other medical conditions. Bile pigments, bile salts, and urobilinogen. If conjugated bilirubinemia is present, it is an indication of severe hepatocellular damage, obstruction to the bile duct, or extrahepatic. Urobilinogen is usually present in prehepatic, jaundice, or hemolytic disorders. Blood. Dipstick is a very sensitive for heme. So whenever there is a dipstick positive hematuria, you have to confirm it by microscopic. It cannot differentiate between hemoglobin and RBC, free hemoglobin and myoglobin. For example, a patient with hemolysis or rhabdomyolysis can present with a dipstick positive hematuria, but you have to confirm it by microscopy. Now we come to the microscopic analysis of the urine. Dipstick cannot identify renal epithelial cells, cast or crystals. Dipstick hematuria needs to be confirmed, as I have already told you. And you do light microscopy, standard light microscopy, which is a low power for the cast and high power for RBC, WBC, and epithelial cell. Now, automatic instruments are also available, like flow cytometry, which gives you a quantitative, and phase contrast microscopy is employed to identify dysmorphic or the RBCs which have changed their shape, which is usually in the glomerular diseases, can easily be identified by special type of microscopy called phase contrast microscopy. Now, how do you prepare slide for microscopy? It's very simple. You centrifuge the urine in a centrifuge. You throw away the supernatant, and the sediment is 1 drop of sediment is taken on the slide, covered with the cover slip, and seen with the under the microscope. No staining is required for doing the microscopy of the urine. Now, in microscopy, what do you identify? Red blood cells, usually a feature of hematuria, white blood cells of pyuria, various forms of epithelial cells, urinary cast, crystals, bacteria, mucus, sperms, and yeast cells, which is due to uh, candida infection. Now, bacteria, mucus, sperms, and yeast cells are not usually seen in the urine, which is freshly passed. But even if you find out the sperms in the urine, it is better not to report because of ethical reasons. Now, usually you don't see RBCs in the urine, but in ladies, up to 3 RBCs are considered as normal. So in male, even if a 1 RBC is present, it is abnormal. In ladies, up to 3 is normal, and above 3 is abnormal. Now, this hematuria can be glomerular, and glomerular hematuria can be microscopic or gross. Gross means you can see, literally see, which is called a cola colored urine, or microscopic, which you detect on microscopy. Then proteinuria, dysmorphic RBC, and breast cell cast are a feature of certain forms of glomerular disease, especially nephrotic syndrome. But if you find a uniform size shape of RBCs, it may be microscopic or gross. It can be a red or pink urine, or there might be clots in the urine. These are all, mostly they are the urological causes of hematuria, like obstruction, stone disease, etc. The other causes of hematuria are tumor, trauma, stones, acute tubular necrosis, UTI, and bleeding disorders. Now, these are the white blood cells. This is how you see the white blood cells, slightly larger than the RBCs with a distinct granular material inside it. Again, the white blood cells. And then comes the various forms of epithelial cells. Squamous epithelial cells, they are large flat cells with central nucleus. Usually they are from bladder or urethra, and it indicates contamination of the urine. Renal tubular epithelial cells are usually not present. They are mostly from the proximal tubule cells, round oval cells, and single nucleus. And it's a feature of acute tubular necrosis and renal allograft rejection. These are the epithelial cells, different kinds of epithelial cells, squamous cells, transitional cells from the urethra, and tubular epithelial cells. Urinary cast. It is difficult to see urinary cast, but you have to be patient and look deeply into the microscope, and you will identify a cast as a faint cylindrical structures. These are usually the precipitation of the time phosphol protein or the glycoprotein. They are found in the tubular lumen. Physiological cast are hyaline cast and granular cast, which are usually seen in fever, exercise, and volume depletion. Few cast of granular type are normal. The pathological cast are the granular cast, which are seen in large number. They are muddy. They are also called muddy ground cast with granules of cell debris. It is a feature of acute tubular necrosis, especially the recovery phase. RBC cast, if you find an RBC cast, it's a characteristic feature of nephritic syndrome or acute interstitial nephritis. WBC cast are seen in pyelonephritis and interstitial nephritis. Renal tubular epithelial cast in ATN and acute interstitial nephritis. Fatty cast in nephrotic syndrome, and broad cast is a feature of chronic kidney disease. The casts are fat. They are larger in size and is a feature of chronic kidney disease. These are the different kinds of casts. Very faint cylindrical shadow you can see on the microscope. Granular cast, cylindrical shadow with a granular material in it. Hyaline cast, RBC cast, lot of RBC in the cast, and WBC cast, lot of WBC in the cast. Maxi cast is a feature of nephrotic syndrome. Hyaline cast is usually normally present in the urine. few cast. Granular cast, if they are in a large number, it usually indicates acute tubular necrosis. These are fatty cast, seen under the polarized lights. WBC cast again. RBC cast. The RBC is a net feature of acute nephrotic syndrome. Crystals. Various forms of crystals are also seen in the urine. Calcium oxalate and uric acid crystals, which are a feature of normal urine, especially those patients who are slightly dehydrated. Large bizarre crystal of any type may indicate calculus disease. Cystin crystals are always abnormal, shows cystinuria. Now, uric acid crystals appear as a form of yellow brown color of different shades. Calcium oxalate crystals are envelope shaped. Cystin crystals are hexagon shaped. Triple phosphate crystals are coffin-lid shaped, and calcium phosphate are long colorless needles. I'll show you the different shapes of these casts. Now, this is the uric acid crystal, calcium oxalate, envelope-shaped crystal, hippuric acid, calcium phosphate, and triple phosphate, which is a feature of characteristic of coffin lid. Usually, calcium phosphate is joined, and then other drugs which are passed in the urine, and 15 crystals are hexagonal crystals. These are the urate crystals. Envelope-shaped crystals of calcium oxalate. 15 crystal hexagonal. Triple phosphate coffin lid crystals seen in the microscope. Now, this was complete interpretation and how to do a urine DR, urine analysis, urine estimation. This is a very important test, and each and every one of you should know how to perform urine DR and to how to interpret. The other test which are performed to assess kidney function is urea. It's a major end product of protein metabolism, and it is formed in the liver and excreted via the kidney. It is the most commonly used marker of kidney function. The normal, either you do it in the form of blood urea nitrogen, the normal range is 8 to 18, or urea, the normal range is 20 to 40. Most of the labs give you urea report, but certain labs give you the urea level in the form of BUN. You just have to multiply the urea with a BUN with 2.12 to get urea level. Or if there is a urea level and you want to convert it to BUN, you have to divide it by 2.12. It is not a reliable marker. Why it is not a reliable marker? Because urea does get reabsorbed from the proximal convoluted tubule and collecting ducts. And this is a marker which should always be used with creatinine. 90% of the urea is excreted through the kidney, but there are other routes of excretion as well, like GIT and skin, which is a minor fraction. Now, there are certain conditions in which the urea is increased, but the GFR is normal. They are hypercatabolic state like fever, thyrotoxicosis, diabetic ketosis, the trauma. If someone is taking high protein diet, if someone has got upper GI bleeding, or if someone is on high dose steroid, in these situations, the urea will be raised, but the creatinine will be in the normal range. Now, there are certain conditions in which the urea is not significantly raised, yet the GFR is reduced. Glomerular filtration rate is reduced. This situation happens in patients who are on low protein diet or are malnourished or starvation, or patients with severe liver disease. Urea is produced in the liver. If somebody has got severe liver disease, his urea will be on the lower side. And in pregnancy, because of hyperfiltration. Now, this is the most widely used marker of kidney function. It is better than urea. Normal range is 0.6 to 1.2 milligram per dl. It is filtered at the glomerular and secreted by the proximal convoluted tubule. It is an endogenous marker, inexpensive and easy to use. It is also used for the estimation of creatinine clearance or eGFR. Estimated glomerular, you cannot perform estimated eGFR unless you have the creatinine values. Now, low plasma creatinine is usually seen in patients who have got small muscle mass, wasting and amputation, small body frame like infants and elderly, low values in female, and patients who have got malnutrition or are on the protein restricted diet, and in pregnancy because of high blood pressure. High plasma creatinine is usually seen in patients who are on high protein diet, exercise, who have got muscular structure, or there are certain drugs which cause a high creatinine level like trimethoprim and cimetidine because of tubular secretion. Plasma creatinine is better than creatinine clearance because it is easy to perform. I have put the question mark over here, but there is no replacement for estimation of glomerular filtration rate or eGFR. So it is endogenous, pre-filtered at the glomerulus and actively secreted. It underestimates GFR by over 10%. So it cannot be replaced for estimation of GFR, but it does help you in identifying the cause of kidney impairment. Now, creatinine clearance of GFR is the amount of blood that kidney can make creatinine free. Each ml, each minute is called creatinine clearance. The creatinine clearance formula is UV upon P, where U stands for urine creatinine, V for urine flow rate, ml per minute, and plasma creatinine is P. You have to collect urine for 24 hours. It should be a precise collection. Creatinine levels in both urine and blood are measured and applied to the formula. Estimation in AKI is only reliable when creatinine production and excretion are in the steady state. So the estimation of creatinine clearance is not important in patients with acute kidney injury. Estimation of advanced CKD is not indicated if GFR is less than 15 ml per minute. Equations for the estimation of GFR are various equations. Instead of collecting urine for 24 hours and doing the actual creatinine clearance test or GFR test, now various equations are available which can estimate the GFR, and that's why they are called eGFR. Now the equations are it is serum creatinine based, no need for 24-hour collection, to be used in caution with AKI. I have already told 3 types of equations are available, and all are available on the net, and calculators are available for applying these equations. One is called Cockcroft equation. This is the oldest equation, very easy to perform. MDRT equation, it requires log and it can be calculated with calculator. And CKD EPI equation is the latest equation, most advanced, and it estimates eGFR quite accurately. So this is the most commonly used equation, very handy, can be used in the wards. MDRT equation requires a calculator, and CKD EPI equation is the most advanced equation to estimate eGFR. Now, Cockcroft equation was first developed in 1976, very useful to be used in caution with AKI. As I already told, the standard formula is 140 minus age multiplied by weight divided by serum creatinine into 72. So if you just have to know the age of the patient, his body weight, and serum creatinine, and you can calculate eGFR. It can be used with simple calculator, can be used in drug dosing as well. MDRT equation is called modification of diet in renal disease, laboratory results for eGFR, MDRT equation. This equation is used by AKU laboratory to estimate GFR, but it is less accurate. It cannot estimate GFR above 60 ml per minute. It does not require weight in calculation. It can be done without weight. More accurate than Cockcroft equation. It should be used with caution in elderly, obese, and patient with AKI. Can be used for drug dosing in renal impairment. Many calculators are available on the web. This is above is the Cockcroft equation, 140 minus age multiplied by weight divided by serum creatinine into centrifuge. This is a modified MDRT equation, requires log. You don't have to remember this equation, but ideally you should know this equation. EPI, chronic kidney disease epidemiology collaboration equation. In a steady state, CKD EPI equation is the most reliable estimate of kidney function. more accurate at eGFR greater than 60 ml per. It can measure GFR more than 60 ml per minute. Can be used with statin C to estimate eGFR, especially in liver cirrhosis, reduce muscle mass, and AKI. Likely to replace MDRT equation in near future, and many calculators are available on the web. This is the CKD EPI equation. Now, after doing the urine analysis or urine DR, and after calculating the GFR, the other tests which are usually performed to find out the cause of kidney disease are CBC, PTA, PTT, urea creatinine electrolyte, which we have already discussed, calcium, phosphorus, alkaline phosphatase, and PTH, because we know one of the functions of the kidney is the calcium regulation by the help of activated vitamin D. So in patients with chronic kidney disease, calcium is usually low. Total protein and albumin for the quantification of the degree of proteinuria. Serum uric acid is usually high in patients with the kidney diseases, in patients with gout, in patients with hyperuricemia. Urine DR in culture, both are done in patients suspected to have urinary tract infection. eGFR we have already discussed, and 24-hour creatinine clearance or actual GFR we have already discussed. Then there are certain immunological tests which are performed in patients with autoimmune diseases like C3, C4, ANA, anti-DNA, especially in patients with SLE, hepatitis B, in patients with hepatitis B presenting as nephrotic syndrome or nephrotic syndrome in the form of membranous glomerulonephritis or mesenteric capillary glomerulonephritis. This we will be discussing when we will discuss nephritic and nephrotic syndrome. HIV can present with the focal segmental glomerulosclerosis, various types of vasculitis like Wegener, NK positive, NK negative, anti-GBM disease. ASO titers are usually measured in patients with post-streptococcal glomerulonephritis and protein electrophoresis in patients with multiple myeloma. These are the other batteries of tests which are usually performed. Now we come to renal imaging. You can do renal X-ray QUB. It gives you renal size and calculi. Ultrasound is a gold standard in the diagnosis of kidney diseases. Very important test. Just by looking at the size of the kidney in adult patients, you can make out certain conditions, establish the diagnosis. It gives you estimate of the size, if there are any cysts present in the kidneys, tumors, calculi, or hydrocephalus. DMSA, DTPA, and MEG scan are the radioisotope scans. They assist you in the diagnosis of reflux nephropathy. DTPA scan gives you estimate of the split function of the kidney, right kidney, left kidney, how much they are functioning. MAG3 can give you both split function as well as the structure of the kidney. CTKUB is now very commonly used to identify stone disease, those small stones which are usually not seen in the ultrasound KUB. CT scan can be performed to exclude tumor masses and malformation. MRA, magnetic renal angiography, is done to identify renal artery stenosis and malformation. And the diagnostic test for renal artery stenosis is renal angiography and in pre-transplant workup. Now, this is the last test, ultimate test, which we perform when we are unable to diagnose kidney disease, either by urine analysis, by doing biochemistry, by calculating GFR, and if you're still in doubt about the etiology or pathological process involved in the kidney disease, you confirm it by the kidney biopsy. It identifies various forms of glomerular diseases and various types of nephrotic syndrome, vasculitis, nephritic syndrome, interstitial nephritis. It is usually done when the cause of acute kidney injury is not established. We do require kidney biopsy. And in patients with chronic kidney disease, if the kidney size is normal with no obvious cause of kidney failure, then you do a kidney biopsy. And in patients who are transplanted, if they are not, if the transplanted kidney is not working properly, you have to proceed with the kidney biopsy. This we will be discussing when we in the subsequent lectures. So in conclusion, urine analysis is the time-tested, inexpensive, and readily available and very informative test to assess kidney function. You should all be knowing how to perform urine analysis and how to interpret the various changes which we see on urine analysis. It provides a basis for further investigation. On the basis of urine analysis, you proceed with other investigation. Doctors should be well versed with methods and interpretation of the results of renal analysis. Urea and creatinine are the basic renal function tests. Degree of kidney damage can be assessed by calculating GFR, which we have already discussed. GFR can be calculated by 24-hour creatinine clearance, which is a gold standard, but it has limitations. It can also be calculated by estimating GFR by various equations. Renal profile assists us in identifying types of renal disease, and imaging help us to assess kidney pathomorphology, structural changes like stone, muscle, obstruction, and function. You have to remember no equation can accurately measure kidney function should always be used in conjunction with history, examination, and clinical status of the patient. This was about the renal function test. In the next lecture, we will start with the glomerular diseases, initially nephrotic syndrome, and then we will proceed with nephrotic syndrome and tubulointerstitial nephritis simultaneously, and then we proceed further with other forms of renal syndrome. Thanks a lot. Thank you very much. Shoaib? कितनी देर लगी?